Number one, I'd like to welcome everybody to, taking the time to join us during this lunch hour. So I think this is the second in many of our webinars that we're going to be offering to the community. I'm Dr. Adam Teichman. I'm here with Dr. Simon Tabshi. We're all partners in PA Foot and Ankle Associates, which is a division of Pace Foot and Ankle Center. So, our practice here in the Valley focuses heavily on foot and ankle pathology. We focus on biomechanics and also just helping patients not just recover, but perform better. And that's kind of what our goal is in our practice when we deal with sports injuries and athletes. And today we're going to be focusing on, how do we keep our athletes moving efficiently while minimizing injury risk? And that's really important when we talk about athletes' performance and how they proceed through that healing process to recovery. Because we know that injuries aren't just random, they're predictable when you understand the system. And the system is the biomechanics of, what goes on. So in that, I'm going to let Dr. Tabshi take the floor and introduce himself. And just real quickly with Dr. Tabshi, he's been with us for a long time. I think he had more hair back then. So, but no, he's a great surgeon and practitioner in our practice, very knowledgeable in biomechanics and also dealing with athletic injuries and recovery, and really focuses on conservative management first before he advances to surgical intervention when needed. So I'll just open the floor to him real quick.
All right, great. Thank you, Dr. Teichman. As Dr. Teichman said, I've been with the practice since 2017, so for almost 9 years. But our practice focuses heavily on pretty much everything in the foot and ankle. Um, we see a lot of overuse injuries as well as faulty biomechanics injuries that happen within the foot and ankle. We also see a lot of fractures. Dr. Mironov, who's also listening to us, does a lot of different ankle fractures, comminuted and not, and has actually gotten really good at that. But we all, within a practice, concentrate on not just the forefoot, but the hind foot, the rear foot, as well as the ankle and even leg for that point. Everything kind of stems proximally, and a lot of the weight distribution is what gives a lot of patients these different pains. So without actually evaluating the entire limb, a lot of patients miss out on their proper diagnoses. And if you're missing out on the proper diagnoses, you're going to be missing out on the proper way to treat that diagnosis. I know you, as well as I and Dr. Akio, we see a lot of second opinions from patients who unfortunately go elsewhere and are not successful in the treatment modalities that are given there. Fortunately, at our practice, we have a lot of different modalities we could do, not just in the office and in the clinic, but we also have our physical therapy associated with us, which has been very beneficial for a lot of patients, both non-surgical and surgical. Um, we have a lot of different things within the office that help with different ailments. We're able to get our hands on orthotics, braces, night splints, things like that, that are going to give patients the proper support that they need in order to, move forward with the different activity levels that they want to participate in. We have the laser therapy, which has helped a lot of our patients with acute and chronic inflammatory processes throughout the past couple of years since we've started utilizing it. So, we're very beneficial in our office to have a lot of different modalities that we can use in order to help patients successfully recover, again, both surgically and non-surgically, and get them down the proper road to recovery and a quicker recovery in order to get back to their day-to-day changes. With that being said, everything kind of starts off with the biomechanics. Biomechanics is one of the key things when it comes to foot and ankle injuries. Most people don't even know they have a faulty biomechanic until they're coming into our door with some kind of torn tendon, an ankle fracture, or something that's going on that unfortunately, I don't want to say could have 100% been prevented, but by getting seen earlier, could have at least been more stabilized and maybe prevented as bad of an injury from happening. A lot of patients, a lot of times, by the time they get an ankle fracture or a torn tendon or ligament or something of that nature, will say they've been having pain for several months before then, and they just thought it would, go away, as many of us do. A lot of times we'll take ibuprofen or Tylenol or whatever we can get our hands on over the counter wise and try to self-treat when, inflammation is really the response of the underlying nature that could have been treated kind of beforehand. We see a lot of overuse injuries. Recently, I've been seeing a lot of ankle, I'm sorry, Achilles tendon, tendinopathy. I actually have a guy coming in today because he actually ruptured his Achilles because of playing basketball. And again, faulty biomechanics. A lot of times we'll go out, we'll do an activity, not stretch the proper way. That also leads to a lot of this stuff as well. Um, we always want to try to focus on from a clinical standpoint of movement quality over movement quantity. How do you get the best out of your movement in order to successfully achieve what you're trying to do without outputting too much effort that's going to cause some kind of injury to happen. Um, do you have anything to add to a lot of that stuff?
Yeah, no, I think you made some great points. When we talk about, injuries, especially with athletes, it's really not because they're doing too much, because they're doing it, inefficiently, right? And
Mhm,
we look at, ground reactive force, and that's really what our goal is, especially when we're preventing injuries, is ground reactive force. So when that mechanics or that foot hits the ground, how is that foot interacting with the ground? If it's not properly controlled, that force has to go somewhere, right? And that's where
mhm,
injuries begin. And from a biomechanical standpoint, we need to really address two things: the stability, the control position, and also the mobility to allow efficient movement. And that's kind of the goal, right? Stabilize the platform and allow mobility to occur so we can actually go through that motion or that sport that they're doing to properly control the mechanics, so make it more efficient for them. And
mhm,
I think that's really where the key comes to biomechanics, is addressing biomechanics so we can prevent injuries from occurring. And what I tell my patients when they come is, 99% of foot problems start with biomechanic abnormalities. And then that 1% is what happens whether they get, a fracture, a tendonitis, or some type of rupture, is because that faulty biomechanics. And our job as the foot and ankle specialists
mhm,
is to address the biomechanical inefficiencies and put them in a more neutral or normal position so they can perform their sports that are occurring. I think the next question is, since understanding biomechanics and how it comes to interact with the ground, is really injury prevention strategies, right? So how do we prevent these injuries, and what's the best way, to have these conversations, with the injuries? So we look at the system as a whole, the biomechanics, how the foot interacts with the ground, and then, maybe you can touch on like athletes themselves, looking at what things do you look at for injury prevention and preventing injuries, because we know that injury prevention is that single biggest predictor of future injuries. So if we can understand the biomechanics and prevent injuries down the road, we really have to understand that, almost like fix the root cause of the problem and
mhm.
not just waiting for the reoccurrence.
Yeah, I think what you said, when you were talking about the ground reactive forces, I think that's a big thing, especially now. I mean, how often do we see now in pro sports, especially in the NFL, all these Achilles tendon ruptures? And I think a lot of that really started as the league started to transition from grass fields to more of the turf. Turf doesn't have that give and quote unquote softness that the grass does. So I really think that's been having a lot to do with the different Achilles ruptures that we've been seeing throughout the NFL. And not just that, even the different tears that people are getting in their ankle ligaments as well as their ACLs, MCLs, everything everything kind of starts at the core. So if not just the biomechanics of the foot and ankle, but also the biomechanics of the knees and the hips, it's a trickle down effect. So if something is off or unstable within the hip, the knees, your first the first place you're going to feel it or get injured is really the foot and ankle region. um And, the way that we treat athletes, even though, we treat everybody the same in terms of stabilization, what kind of athlete are they? Is it, is it these the little leaguers that we're seeing in the office that are going to be treated different than the collegiate athletes that we see? The stabilization and the mentality behind the stabilization of their biomechanics is the same, but the way that we achieve it is different, obviously based off of each patient. Um, when it comes to the average Joe that we, usually see in the offices with these different injuries, how do we uh, so trying to prevent it is by trying to, one, I think stretching is key. Not many of us are out there performing sports activities day in and day out. A lot of us, myself included, I'll go out, shoot some basketball with the kids once a month or once every other month or whatever it is. And we think we're NBA stars and we're still young like we used to be, where we're going to recover the same the next day. And that just doesn't happen. Um, and I think what we often forget is that one of the biggest things that helps with stability and trying to prevent injuries is stretching and diligently stretching both before and after the activity. If it's something where, if it's a patient who has had injuries long ago, whether it's an ankle sprain or anything like that, I'm a true believer that anytime they're going to perform rigorous activities thereafter, they should be utilizing some kind of an ankle brace, doing some kind of neuromuscular training programs that's going to help in order to make sure they're optimal for the different activities that they're going to do. You want to look at the different factors that can affect uh, and cause injuries. There's both intrinsic as well as extrinsic factors. Intrinsic meaning, the strength deficits. Is there, how's their ankle stabilizers, the proximal hip control, their foot core, different mobility limitations, what's their ankle dorsiflexion? I think like 75% of the population has some kind of equinus, whether we want to admit it or not. And I think, and equinus, I think, is one of the biggest root evils in the foot and ankle with everything, no matter what it is, whether it's an ankle injury, whether it's plantar fasciitis, whether it's metatarsalgia, no matter what it is, there's usually some kind of equinus factor that is associated with that. Um,
Talking about Aquinas, though, I think that's more, of a compensation thing for a
mhm.
biomechanical abnormality.
Yeah, agree.
Pes planus, you could look at cavus foot, all these things, depending on the Aquinas deformity. But I think Aquinas is really, a complication of a deformity that's further progressing, when
Mhm.
you mention Aquinas. And I think that's a great point is because when you have Aquinas, you shorten your gait, it causes an adductory twist. So it really messes the biomechanics
A lot of
as a
stuff.
whole.
Yeah.
So, really understanding that, I think the biomechanics, and that's kind of where we specialize as a group too, is looking at biomechanics,
Hmm.
not only from a athletic standpoint, from a surgical standpoint too, to
Hmm.
understand what the right procedures are for these athletes that come in, and you mentioned, lack of ankle dorsiflexion. That's important to understand, not only from a Aquinas standpoint, but also there could be other things that are causing it with arthritis, bony blocks, things like that can cause
Hmm.
lack of dorsiflexion. And I think you mentioned some good points about intrinsic and extrinsic factors as well. Like extrinsic factors are looking at, like maybe they increase their volume of activity or poor recoveries, like you said, and also surface changes, talking about, grass to turf. All these things can be cumulative and overload with adaptation that can cause these injuries. So understanding, the extrinsic and intrinsic factors when you look at athletes for prevention are important.
Hmm.
And so what are some things that you would recommend as modalities, to help prevent some of these injuries? Some things that we recommend here in our practice, whether it's addressing biomechanics and things like that. What would you kind of recommend as all? And then we'll hit some common sports injuries that we see.
Different ankle bracing, I think, is really key with a lot of this stuff.
Mm,
Thankfully, in our practice, we do have a lot of different ankle braces that we could get our hands on, depending on the patient. For some patients, depending on what their what they're deficient in might do better with a figure eight brace compared to a Ritchie brace. So it really comes down to having the physician evaluate the patient and seeing what's really best for them in order to try to prevent injuries as they begin to, get into their activities, start their activities, whatever it may be. Um, in terms of equinus, using a night splint at nighttime in order to really stretch the Achilles tendon. Different, I know myself, I know you do as well. I'm sure Dr. Mironov does as well. I give my patients stretching exercises anytime they come in with any type of abnormality or any tightness in the Achilles, in order to really stretch and strengthen the areas. I think one of the biggest things, especially, as we get older, that I discuss with patients is gradually getting into their activities instead of going full blown. You never go into the gym and start lifting, 40-pound dumbbells. You want to start small and kind of work your way up. And, I think that's one thing post-operatively that I really try to drill into my patients' heads as well, after we've done any type of lateral ankle reconstruction or a tendon tear or whatever it may be. Everybody, we think our bodies are going to heal and get back to our our level of activity that we were prior to the injury. And unfortunately, the body doesn't work that way. And as we get older, it works even less that way. So it's really setting the level of where we want them to be and at what point we want them to get there. And by using these different ankle bracing, I do, strapping for some of my patients as well, depending if it's needed. Um, in order to really provide support for that injured area. And in order to provide support for that injured area, you also want to strengthen the ligaments or tendons or whatever it is in that area in order to alleviate the pressure that that injured ligament or tendon is undergoing, to give that time to heal and letting some of the other um, soft tissue structures in the area to take the brunt of that load in order to really allow for maximal recovery.
So yeah, and I think load management is really important when we
Hmm.
talk about the support of biomechanics. The other thing that I want to know your thought on is like orthotics. So,
Okay.
we see a lot, like you said, biomechanics, and I always
Hmm.
tell patients that being a podiatrist, we always start from the ground up, right? So we
Hmm.
know that ground reactive force happens, abnormal mechanics happen, and then up the chain it just goes haywire, right? It can cause medial knee pain, it can cause
Hmm.
hip pain. All these things can go wrong as the foot interacts the ground when that normal neutral position goes haywire
Hmm.
for pronation or supination. We know what
Hmm.
those are the two main factors that affect the foot. So what are your thoughts on orthotics in injury prevention and addressing biomechanical instability?
Orthotics help significantly. Um, I mean, I've been wearing orthotics for almost 25 years at this point, and I could tell the difference between wearing orthotics or not. But the orthotics, especially, we have to look at the two different types as well. A lot of times, I more favor the custom orthotics. We're able to actually mold it to the exact preference of the patient's foot that we're actually assessing. We're able to add the different paddings, either uh, some kind of wedge to put the patient more in a varus or in a valgus position, in order to provide whatever support that we need. Having that orthotic and having that proper support. So orthotics are meant to really put your foot in a position that's going to give it the most optimal stability. And by having that optimal stability and having that orthotic, well, the orthotic is one, it's going to help to prevent a lot of the pronation that we have. If we're able to prevent a lot of that excessive pronation or supination, depending on what kind of orthotic the patient has, well, we're going to prevent ankles from rolling, which is going to prevent, the whether it's a fibular fracture or lateral ankle ligament tears or peroneal tendon tears, as well as, you know, preventing excessive pronation, where you're looking at the other side of the ankle and preventing a lot of that wear and tear on the PT tendon, which a lot of people end up getting. So orthotics, like you said, you're starting from the ground up. You're not going to build a 4-foot story building starting with the roof. So if you don't have that proper structure and proper support, like with an orthotic, you know, everything else is going to collapse as well. And that's where you're going to start seeing that medial knee or lateral knee impingement, depending on the patient.
I think that's a great analogy. You can't build a 4-foot story building with starting on the roof, and that's kind
Mhm.
of how we treat our patients is, building from the ground up, and really biomechanics is, I think, is an integral part of understanding any pathology,
Mhm.
that comes in. And orthotics, I think, are a great way to neutralize negative forces that are impacting biomechanics, and putting that foot into more a neutral position, as well. A lot of people also talk about, like shoe gear, but we always say, when putting yourself in orthotic kind of opens up the door to try a different pair of shoes
Yeah.
versus motion control or a neutral shoe, you know, um, and yeah, I think at the end of the day, though, like, and I think what you were trying to get at too is talking about all the benefits of looking at lateral column and medial column instability is really
Mhm.
neuromuscular training, right? Looking at balance, proprioception, controlling strength, that has been shown significantly to reduce injury rates is what we talk about. And that's important, evaluating that. So, I think what we should do now is focus on some common injuries that we see. You know, um, I'm gonna go right to plantar fasciitis because I think plantar fasciitis is probably one of the most common ailments that we see in our practice, probably in the
Mhm.
40 or 50-year-old population or higher. Weekend warriors really see it
Mhm.
a lot. Like you said, people who just start to go out and do some type of activity usually get it, but common as we age, someone we're eventually you get some type of heel pain, and the most common type is plantar fasciitis. And I think it's really there's two things when we talk about plantar fasciitis. It's inflammation, and then we come back to biomechanics again,
Mhm.
right? The biomechanics and the inflammation, and really about biomechanics looking at load tolerance and then controlling inflammation. So why don't you talk a little bit about, plantar fasciitis and, what your thoughts are on how we treat it and kind of staging that management, that progression to healing.
Yeah. So, with plantar fasciitis, there's two ways to look at this. So there's the fasciitis aspect and there's the fasciosis aspect. The fasciitis is the actual inflammation that happens in the plantar fascia. The fasciosis is more the repetitive trauma that occurs to that area that eventually leads to that fasciitis. The thing with plantar fasciitis that I think is the biggest mistake that a lot of patients do is fasciitis is hard to treat by yourself. And I know a lot of patients want to try to self-treat, with over-the-counter medication and things like that. That's not how fasciitis works. As well, you know, unless you're gonna go home and be off your foot for 2 to 3 weeks and let the inflammation just subside, that's not what the average person can do. Most of the patients that we see are on their feet for long periods a day. And like we were talking about, having a proper orthotic is what's going to help to support that plantar fascia because it's going to prevent it from constantly undergoing that burden and the repetitive strain to that area. But without treating the actual inflammatory component of the plantar fascia with oral medication, injections, laser therapy, strapping, taping, stretching, night splints, all the different things that we do for our patients in our practice, you're really never gonna be pain free. And I always tell my patients, every time I see them for plantar fasciitis, it's a two-step thing. Step one is getting rid of the inflammation. Step two is how do we try to prevent this from coming back? And are we 100% going to prevent it from always coming back? We don't know. We can't predict how the body's going to be, how the body will respond, or anything like that. But my usually my protocol is, a patient will have a mixture of both injection therapy as well as oral medication. And I think the combination of both really helps. And for me, I keep attacking the inflammation until the patient has absolutely zero pain clinically. And I tell every single one of my patients, it's like a fire. If you don't completely put the fire out and you even have that little spot of inflammation left and you leave that untreated, it's going to re-erupt again. And then we're both going to be angry at ourselves. So if you don't completely um, get rid of the inflammatory process that's going on with the plantar fascia, patients are not going to be completely pain free. And we always have to set um, kind of set proper expectations for our patients where, if this becomes something where we get rid of the inflammation, 3 weeks later, it comes back, we're able to get rid of the inflammation again, but it becomes a recurrent cycle, it's that those patients that end up requiring something surgically done. So this isn't, unfortunately, plantar fasciitis can be something where someone heals within 1 or 2 treatments, or it could be something where, a patient unfortunately needs to undergo some kind of surgical intervention in order to really rid this pain. And I kind of try to set the expectation for patients that, I mean, how many times does a patient come in and say, I've been dealing with this for a year and a half? More often than not. So I always try to set that expectation. Well, if it took a year and a half to, if you've been dealing with this for a year and a half, we're not going to get rid of it in 3 weeks. So really setting the reality of how these things are treated. This stuff takes time. Um, and our goals as physicians, especially in the foot and ankle, is, within the 4 to 6 weeks, we hope that the patient is about 50% better. And to us, that's a win. It's just, as long as the patient is willing to work with us, because it's a give and take. We'll be able to treat the inflammatory process, but the patient at home also has to be wearing the orthotics that we're recommending and that we're getting for them, using the nice splint, stretching. Stretching is very, very key with things like this. So, each one of us has a different protocol, but I think all of them are kind of similar to each other, um, in terms of what we tell our patients and what we expect them to kind of undergo throughout the course of the treatment cycle.
No, and I think the takeaway is no foot pain is normal, and the
Exactly.
longer that you ignore it, the harder it is to treat. Whether it's
Hmm.
plantar fasciitis, Achilles tendonitis, whatever,
Hmm.
whatever pain in the foot is going on, the more that you put it off to get it treated, the harder it is to manage. And
Hmm.
especially with plantar fasciitis, that the quicker that you can get in to see us, the easier it is to treat versus like you said, if you wait like a year and a half, it's a challenge because of the fact that fascial band is a little thicker now.
Hmm.
It's atrophied a little bit, and the injections are going to work well, but it's going to take a little longer and a little more patience, I should say, to get better. And there are people who end up in the surgical mode, but that's a small population compared to the
Yeah.
larger population that
Yeah.
responds. And also orthotics, right? Orthotics
Hmm.
play a big role at the end of the day. And like you said earlier on, orthotics are made to prevent this from reoccurring once we
Hmm.
get the acute phase or chronic phase of inflammation or control, and that's really important. And people, I think the biggest takeaway is, like I said earlier, no foot pain is normal. If you do have foot pain, it should really be evaluated,
Yeah.
especially foot pain that is not going away after a couple of weeks. It really should be evaluated, and it's something that we could probably treat pretty easily.
Yeah.
Um,
A lot
and,
quicker.
yep, and you mentioned
Hmm.
earlier second opinions, and we see a lot of second opinions because I think a lot of people don't focus on the biomechanics.
Yeah.
And I think if you can understand the biomechanics and pathology of what's going on, we can manage these things, and we're very successful. I think all our doctors are successful in our practice in managing complicated second opinions and getting patients to a point where they're going to be pain-free conservatively, the majority of time.
Hmm.
So that's great. So let's just talk about, a little bit about, stress injuries as well, like stress fractures, and all
Hmm.
stress that goes on, because we know that, bones either adapt to stress or fail under it. And that's really, there's no middle ground, right?
Yeah.
So when they fail, that leads to fractures as well. And so often, what are these, like, we see that stress injuries are tied to, training errors, sometimes nutrition deficits, and also biomechanical insufficiencies or
Hmm.
inefficiencies, I should say. So understanding that, like how do you manage someone who has a possible stress fracture, and like what do you look for when they come in, and what type of things should patients be aware of to see maybe they are developing a stress fracture?
Um, a lot of times the stretch fractures occur after prolonged activity or being on their feet more than they typically are. It's funny, I've actually had in the beginning of the school year, I had probably three teachers come in with stress fractures because throughout the summer they weren't on their feet that much. And then they went back to teaching where they're on their feet all day, and all of a sudden, boom, they started having pain to a certain area of the foot, which ended up being a stress fracture. So the thing with stress fractures is it's like you said, it's increased load to that area. Um, so, I don't want to keep beating it, but biomechanics is everything. Having the proper support and proper shoe gear while you're doing different activities is also key as well. Um, and with the thing with stress fractures is that even if you start having pain and you go to get an x-ray at a patient first or urgent care center or wherever it is, x-rays might be negative. That doesn't mean that you don't have a stress fracture. It usually takes about 10 to 14 days before bone demineralizes in order to actually see if there's a true stress fracture to the area. And a lot of times, even at that point, it doesn't pick it up, and we end up sending for an MRI, and MRI picks up that there's been some kind of stress riser to that area in the foot and ankle. It's most commonly seen in the metatarsal bones, um, where they'll have stress to that area. Clinically, it's usually point tenderness. They have pain in a certain area of the foot or of the bone. The way that I treat it, I mean, I offload them right away, whether it's in a cam boot or a surgical shoe, and have them uh, ice, elevate. Sometimes I'll send an anti-inflammatory just to decrease the discomfort and the, again, inflammatory reaction that's going on within the bone, and have them follow up after a couple weeks. And at that point, hopefully they're feeling better. If they're feeling better, that's a good thing. But these stress risers or stress fractures can end up being full blown out fractures if they're not treated quickly enough.
or offloaded, or
Yeah, exactly.
no foot
Hmm.
pain is normal, right? So don't
Exactly.
ignore the foot pain, because those stress fractures can definitely become complete fractures
Yep.
and then possibly a surgical candidate
Surgical. Exactly.
or
Yep.
displaced.
Yes.
So yeah, I mean, we listen. So some other stuff, we did talk about ankle injuries a little bit,
Hmm.
ankle sprain, and I think we kind of hit Achilles tendonitis. Let's talk about footwear selection. Because your shoe is really the only piece of equipment that interacts with the ground every single step. So
Hmm.
again, it really comes down to biomechanics, right? So
Hmm.
when we talk about footwear selection, and understanding proper choices, and let's just talk just generally about foot selection, like,
Hmm.
whether, there's three types of shoes we can look at, motion control, there's neutral, and then there's basically a minimalist shoe, right? And
Hmm.
tell me your thoughts on those three types of shoes, and which patients they're good for, and just in general.
So I think the biggest misconception with a lot of patients in selecting shoe gear is that a lot of them are looking more for the cushioning, more like the memory foam and all that, instead of the actual proper control of the foot.
Yep.
And I mean, there is a bunch of shoes that are out there that quote unquote have better arch support or better motion or better control. And then when these patients spend all that money on it and they bring the shoe in, and the shoe really isn't the proper shoe for that patient, or it's not providing the proper amount of support for that patient. Guidance and motion control are really the two biggest things that matter the most with these type of things. I tell patients, if you have the proper orthotic, you can get away with a lot more different types of shoes than you would without an orthotic, because the orthotic is what's going to control the actual biomechanics of your foot a lot more than the actual shoe would. And by having the proper orthotic in your shoe to give you that proper stability and support, you can get away with, you know, probably 90% of the shoe gear that's actually out there. Again, it really depends on the shoe and the shoe brand. Um, but how you have to look for shoes that are not just comfortable, but something that's going to give you a little bit better support, especially for our nurses or our teachers or our Amazon workers who are constantly on their foot every day, where that wear and tear. Um, so I think, to me, I think it starts mainly at the actual orthotics. I think having the proper orthotic in your shoe will allow you to um, maximize and, have a broader range of shoe gear selection than you would if you did not have that proper orthotic in your shoe.
Yeah, so that's great. So like, someone who pronates a lot, putting the
Mhm.
orthotic in the shoe, they can go from a motion control shoe to a neutral shoe.
Exactly.
And one thing I just want to mention real quick is minimalist shoes, the
Mhm.
zero drop shoes, that are
Uh,
really a big thing. I'm personally not a big fan of them. I
Neither am
don't
I.
like them. My theory is that, we are grown up in a shoe and our intrinsic muscles are built around footwear.
Mhm.
And if you go to a zero drop or minimalist shoe, it's like walking barefoot. And that's really where I think things go haywire. Unless you have a perfectly neutral foot, minimalist shoe is fine. But people who have a flat foot, they pronate a lot, they supinate a lot, minimalist shoes are going to be a problem down the road. And I think people really have to think of footwear as, as part of their equipment, right? It's a critical interface in controlling motion. And it's not just cushioning, it's guiding and providing stability. And that's what
Mhm.
people really have to think about with shoes. And that's where I think motion control shoe comes into play, addressing hypermobile feet with that are associated with pronation, or a neutral shoe can come into play with people might supinate a little bit, or that neutral foot where they don't pronate that much. So yeah, I think it's really important to understand that, and I think orthotics play a big role and are an added benefit, to choosing the right shoe, and
Mhm.
offers people more of a variety when they have the proper orthotic in to look at, certain shoe gear and shoe wear, as well. Um, so do you like, first let's talk about the big picture. Do you have any other thoughts of what we talked about today? Like, our goal isn't just to get you back, it's to get you to back better, right? And
Mhm.
understanding that movement quality is the foundation of durability, meaning that the better we can move, the more durable your body is in handling these stresses. So I don't know if you have any other big picture thoughts on, things that people can think about, whether they're starting an activity or coming out of an injury or prevention.
I honestly, I think the biggest thing is gradually integrating yourself into that activity. I have a bunch of patients that, as the weather's getting nicer, they want to start going for a walk. Well, I'll, tell them, start with half a mile the first day, work yourself up to a mile, work yourself up 2 miles. Don't think that just because a year ago you were doing 3 miles a day, that your body's gonna right away go back into doing 3 miles a day. Really try to gradually increase the amount of activity that you're doing in order to try to prevent injury. Um, and again, making sure, like we just talked about, you have the proper shoe gear in order to help give you that support and stability as you are getting back into your different activity and activity level. Um, what even, like we touched on this earlier, but bracing and taping when it's actually appropriate, in order to give you better control of the biomechanics of your foot. That's something as simple, if people are unsure of what type of bracing or taping or wherever it may be that they need, it's as simple as coming to see one of us and we can address that and make sure they're in the most optimal um, shoe or brace or whatever it may be that's going to allow them to pursue whatever activity they want to do, and making sure they get into that activity with the least amount of um, injury risk as possible.
Yeah, no, that's great. It's really important, to basically look at everything in the bigger picture and understanding, everything that goes on with the foot or ankle or whatever their pathology is, and then address that with the proper, device, whether, like you said, it's bracing, taping, or orthotics. Because our ultimate goal is simply just keep you active, efficient, and doing what you love without interruption. That's kind of our goal. And
Mhm.
being podiatrists, like I said, we work from the ground up. And I think the biggest takeaway is, no foot. I keep saying it, but it's true that, no foot pain is normal. And if you do have foot pain, you should really seek out the advice from a specialist, such as a podiatrist and us at PA Foot and Ankle, because of the fact that we are the foot and ankle gurus, I call it. We understand everything from, biomechanics to pathology to, you know, return to play quickly and efficiently, and providing you the proper direction of what you need to do, to move forward pain free. I think that's an important takeaway from that, and choosing the proper footwear and understanding the pathology and understanding when to return to activity. And one thing I just really want to touch on, which I forgot to talk about, was, you mentioned, children with like the little leaguers and things like that. So you're talking about, pain in kids. The most common thing we see is heel
Mhm.
pain, calcaneal apophysitis, which
Fasciitis,
is
yep.
a growth plate injury, which is inflammation. And I think that's one of the most common things that we see, and the most
Mhm.
common questions we have in our practice is, if it lingers, why isn't it getting better? And when will it get better? And how do we treat it so they can basically get back to their activity?
Mhm. Uh, if for something that lingers, I always, whenever a child comes in with calcaneal apophysitis, my first line is proper offloading. Depending on how bad it is, I'll make some patients non-weight bearing, stop them from doing any activities for about 2 to 3 weeks, send them to our physical therapists, and have the parent give them either Tylenol or ibuprofen twice a day for about 2 weeks to really get that inflammation under control. I'm glad you mentioned that because a lot of people say growing pains. I don't believe in growing pains. There's a kid should not be in pain. Does that mean that there's something going on? There's something biomechanically going on. If they're having knee pain or back of the heel pain or wherever it is, kids shouldn't be having pain. And is it something where they're just not stretching enough? Could be where they're getting shin splints and things like that, and they're just, they're not stretching enough. Is it more of a biomechanical thing where having the proper orthotic is gonna give them the proper support they need so that they're not having pain? Could be that as well. There's really no way to determine without actually evaluating the patient. But whenever I cringe anytime someone says, "Oh, it's growing pains," I don't believe in growing pains. Kids are not supposed to be having pain, and if they're having pain, that's the body's way of telling you something is wrong, something has to be fixed, something has to be addressed. Doesn't mean that they have to have surgery, but that means that something is physically wrong in their biomechanics that has to be fixed and supported in order for them not to be having that pain.
Yeah, and that comes back to the saying again, right? No, no, I keep saying it,
Exactly.
but it's true, right?
It's
And
it's
that's
100% true.
the biggest takeaway is, whether you're young or old, no foot
Mhm.
pain is normal, especially
Hmm.
if it lingers for a long time. So,
Yep.
well, we definitely ran over time. Listen, we could talk for this for hours on this topic, but I do appreciate you taking time out of your
Yeah,
day
thank you.
and to talk to us. It's Dr. Simon Tapshe's partner in PA Foot and Ankle Associates. He is well versed in sports medicine and also surgical management of any type of foot and ankle condition. He did mention briefly Dr. Mirnoff and Dr. Rocky are also partners of the practice as well. And Dr. Rocchio specializes in Charcot reconstruction, dealing with diabetes, which we will have an upcoming webinar on that. And Dr. Mirnoff is one of our trauma surgeons for foot and ankle trauma. And we will have a webinar on that as well. And it'd be a pleasure to talk to all of them. But I want to thank you again for taking the time out of your day today to really give us an understanding on sports injuries and talk about some of your expertise, which I think was very helpful. And I hope people were knowledgeable. I'm really going to open up quickly to anyone who has a question. I know we have a couple people on. If anyone has a question that they'd like addressed by Dr. Tabshi. Well, if anybody wants to listen to it again, this will be available on our YouTube channel, and we'll have a podcast edition updated soon. And it will be available for repeat as well. So again, thank you everybody for your time, and we look forward to next time.
Thank you.
Thanks.